Bridget's amazing. Bridget's one of the individuals in the third year of her K-12. She is trained as a neurologist clinically and is an expert in autonomic function clinically. Mount Sinai, where she and Jessica practice, is one of the few places in the United States that sort of specialize in doing this autonomic testing and in treating individuals with conditions like PATS. But the other set of conditions that Bridget takes care of are migraines. And what she's really going to talk about today is migraine and the interplay of migraine and autonomic function. Bridget?
Thank you so much, Dan, and thank you to the Planning Committee for inviting me. So, chronic migraine, more than just a headache. So my only disclosure is that I spent about a decade before my clinical training as a bench neuroscientist. And I think this is important because it shapes the way I view the treatment and our research on chronic migraine, and it also shapes how I talk to patients. So this is data I collected a long time ago in my graduate lab, and we showed that early prenatal stress changes the number of receptors in the hippocampus, which is a brain region that's really important for learning and memory. And this decrease in receptors leads to an upregulation of our stress response system. And so if you think about this for a second, right, you're exposed to stress during a critical time period, your brain is preparing you for a stressful life, right? And it increases the activity and the sensitivity of your stress response systems. And so this is, of course, adaptive if we need to escape from a lion, right? But perhaps not so adaptive in the life we live in now. And so today I'm going to cover the topics that I speak to patients about during a new patient visit. The first question that we always tackle is, do I have a migraine? The second question is, why do I have migraine? The third is, what is chronic migraine? And this is a question I often get because of commercials, which will advertise treatments that are only approved for chronic migraine. And then the last and most important is, how can I feel better? So, do I have migraine? If your pain is severe, debilitating, and you have a general upregulation in your sensory sensitivity, the answer is probably yes, right? There's other primary headache disorders, but this upregulation of your sensitization to odor, to touch, to light, to sound, is part of the diagnostic criteria for migraine. I like to think of, and this is where my bias comes in, but I like to think of migraine really as a problem that is described best by systems neuroscience, right? This is a paroxysmal pain disorder that's a change in our gain, right? Sensory input gets multiplied. It's like the amplifier in Dan's analogy, right? The volume is turned up. And so why is this happening, right? So in the brain, during a migraine, imaging studies have shown us there's dysregulation of brain excitability, there's altered blood vessel behavior, there's changes in chemical messaging. Not one thing causes this, right? It's a lot of things. The trigeminal vascular system, it sits at the interface between the brainstem and the high cervical neck, which is important, and we'll get to that later. And so it starts off as a local problem, right? It's activation of this, we call it ganglion, which is just like a big collection of nerves, and the release of inflammatory and vasodilatory substances in the brain. Now, when patients come to my office, they usually want to talk first just about the pain. And one of the first things we talk about is that it's not just pain, right? And I ask them about symptoms that happen before the pain, which often are interpreted as triggers, right? So I have a piece of chocolate and now I have a migraine. Well, you were probably craving that chocolate because your migraine really had already begun, right? We know that there are changes in certain brain regions that make us thirsty or hungry or crave sweets or salts, right? It's now we know from more recent research that this is not a trigger. It's really that your migraine's really likely already in progress. And for 30% of patients with migraine, they can have what's called an aura, which is really a focal change in sensory perception. It's often visual, but it doesn't have to be. It can be a change in speech, which is really identical to the speech changes you can experience during a stroke, except these are reversible. Right? And then the headache comes, which we talked about, involves the sensory sensitization, as well as nausea, orthostatic intolerance, which is particularly debilitating. And then when the pain ends, very often the sensory changes and some of these we call them non-cephalgic or non-headache related symptoms persist. And the whole episode takes between 4 and 72 hours, right? And although it's terrible, right, in most of the 40 million people in the United States who have migraine, it is an episodic disorder, meaning in between these attacks, you go back to your neurological baseline, right, and you're pain-free. However, in 3% of patients, every year, chronify. So as migraines become more frequent, patients stop returning to their neurological baseline, and these symptoms become a continuous state. Fatigue, impaired cognition, mood alterations, orthostatic intolerance, they become constant, right? And these sort of non-cephalgic or non-painful aspects of chronic migraine are very often more disabling than the headache itself and the pain itself, right? Because particularly orthostatic intolerance is often, but that's what patients tell me keeps them in bed, right? They can't drive their kids to school, they can't go to work if they feel dizzy and sick getting out of bed. And so, again, as a neuroscientist, I think of, chronic migraine as there's something different in the brain, right, about chronic migraine than episodic migraine. And it likely has to do with synaptic plasticity, right? New connections are being made, changes in connections are being made. And so I talk about this with patients, right, who are coming in with years of chronic migraine. And I think, I'm writing this grant, and the beginning is, the societal burden of chronic migraine, and it's $30 billion. And I have trouble with that because it's hard to quantify the cost, right, of chronic migraine. But I thought this article from the Times did a really good job. And it follows a woman, Paula, who's considering the medical assistance in dying program that's in Canada. And I'm going to read you what Paula says, which is she started thinking about MAID in the spring of 2023 after suffering a head injury. And in the days following, she had vertigo and a migraine that wouldn't go away. And over the years, she had collected varied and sometimes competing diagnoses: fibromyalgia, chronic fatigue, chronic pain, chronic migraine. And I want to pause here for a minute and highlight or bring our attention to the fact that this was written by a fantastic journalist who's, 10 years, she's been doing this for 10 years. But she views these diagnoses as competing, right? And if you're a pain researcher and you know what chronic overlapping pain conditions are, you know that this patient doesn't have competing diagnoses. She doesn't have 7 different problems, right? She's likely one problem in the brain. And so she describes that the symptoms get worse when she's alone, which I think is also very important and something I hear a lot from patients. But she gets dizzy, she vomits all the time. She says it's like the world is spinning. And again, there's a focus on the orthostatic intolerance, right? The inability to remain upright, to have the world stay in place. She couldn't focus, she couldn't cook, she couldn't do laundry. She felt like her brain was going to blow. And of course, as we know, right, we don't have great diagnostic tools for nociplastic pain. So she's been to the emergency room dozens of times, and physicians can never find an obvious cause for her problems, and they tell her she has a variety of mental health conditions and to seek therapy. And I think this is also really important to remember that patients with chronic migraine have a very high risk of suicide. So 47% of patients with chronic migraine with aura reported suicidal ideation, and 13% report previous suicide attempts. This was a large epidemiology study that was done a couple of years ago that is important. So, why does Paula have all of these different conditions? This pain that's really throughout her body and impacts really every aspect of her life. And Dan alluded to this, which is that, the autonomic nervous system is one system that innervates every organ system we have, right? So remember from your high school biology class, right? There's two components. There's the sympathetic fight or flight, which increases heart rate, increases blood pressure, release glucose, cortisol, and then there's the parasympathetic, which is the brings us back down to baseline. It's the rest and digest, right? Primarily your vagus nerve. And the autonomic nervous system does something really important, which is that it's maintaining our blood pressure within a relatively narrow window, right? And this is critical because our brain needs a constant amount of blood, right, of oxygen to function properly. And the autonomic reflex that does this is called the baroreflex. And we hypothesize that in patients with migraine, this reflex may not be working particularly well for a couple of reasons. One, during periods of stress, and certainly migraine is stressful, the baroreflex sensitivity goes down, right? And this serves a very practical purpose of allowing our blood pressure and our heart rate to go up simultaneously. In addition, we know that inflammation and endothelial dysfunction, which are two pathologies that are a part of migraine, also decrease the sensitivity and the function of the baroreflex. And so what we did as part of my K-12 project is we looked at autonomic reflexes in patients with migraine. We looked at patients who had low frequency migraine and high frequency migraine, chronic, episodic, the whole gamut. And we looked to see if this might explain their orthostatic intolerance. And this is our autonomic laboratory that Dan alluded to, and there are just a few of these in the country. It is expensive testing and time consuming. And this work has been beautifully done by my amazing study coordinator, Maya Campbell, who I'm very grateful for her hard work. And so we showed that reduced baroreflex sensitivity is associated with both POTS, right, which is the most common disorder of the autonomic nervous system. It results, it's really a phenotype, right? There's lots of different reasons your heart rate can go up when you stand up. And it also associates with the chronification of headache, right? So patients with ARD, which is autonomic reflex dysfunction, had a 2 to 3 times greater likelihood of having chronic migraine compared to episodic migraine. And then we showed, and others have also shown, that dysautonomia and baroreflex dysfunction is not good for the brain, right? Because you're going to have perfusion issues, right? Cerebral autoregulation gets dysregulated if your baroreflex is not functioning properly. And so there's other consequences of this. So the failure of the baroreflex and of peripheral autonomic reflexes in patients with chronic migraine, if it leads to cerebral perfusion, there's other backup stress systems, right? We know the body is going to have a response to this that involves I like to call them our backup but our stupider stress response systems, right? They just flood the system. They're not targeted, right? They're not going to specifically increase the vasoconstriction of blood vessels. Instead, they pump out catecholamines like norepinephrine, epinephrine, adrenaline, cortisol. And so we feel stressed, right? That's why we don't feel well. And I can tell when a patient's having a migraine or recently had a migraine when they're walking, when I call them into my office from the waiting room, right? I can see their pupils are dilated. They might look a little sweaty. They're walking slightly unsteadily, putting their hands against the wall. And this is because their stress systems are in fight or flight. And so we did show, in fact, that one specific type reflex that we used with a cold pressor test did predict an increase in heart rate in the tilt table test. I do spend time with patients talking about this. I spend time going over physiology, and very often patients will say, okay, great, I want this testing because I want to know if this is why I'm dizzy. And I caution them a little bit because we're testing one part, right, of the autonomic nervous system, which is that efferent part, the part that's going to the organ system, that's releasing the neurotransmitters, that's causing our heart rate to increase. But we haven't talked about the afferent system, which is the nerves that go from our organs back to the brain to tell us what's happening, right? How did our blood pressure drop? Those are vagal afferents with an A, right, that go back to the brain. And these sensory afferents are really important in what a process Dan mentioned called interoception, right? It's how we know and how we feel, how fast is our gut moving, how fast is our heart beating. And so, yes, you might feel ill when you stand up because your heart is racing or your blood pressure goes too low or too high. But like the x-rays, you might not, right? This data shows that a large percentage, about 2/3 of patients with orthostatic intolerance do have a cardiovascular abnormality that explains why they feel sick, right? And that's due to autonomic reflex dysfunction. Their blood pressure goes too high or too low. But what I wasn't expecting was this big white box of patients with a normal response, right? So these are patients who don't meet any diagnostic criteria for an abnormal cardiovascular response to tilt, and yet they're still telling us that they feel sick during the tilt table test. In addition, right, I've got patients who are asymptomatic. I have patients who are asymptomatic, and yet they have dysautonomia. They do meet criteria. So when Dan was talking about the x-rays, right, and the joints, feels very analogous to that, right? Some people with big swings in their blood pressure and their heart rate are gonna feel symptomatic, and some people are not. And so we're calling this sort of discordant orthostatic intolerance. And I think it goes back to this idea that in nociplastic pain, it can be really hard to find a diagnostic test that provides the patient some information about why they feel the way they feel. And that's hard. And so we further looked at this discordant orthostatic intolerant population, and we saw that, interestingly, headache frequency was not the determining factor. It really, although patients with discordant OI, so again, the discordant OI means patients who feel sick but have a normal autonomic nervous system response to the change in their body position, 88% of them had a non-headache COPC. So this is the second COPC. Compared to patients with migraine without OI, only 20% of them had a non-headache COPC. They also had higher scores on we created like a multi-sensory sensitization score that asked patients, how full do you feel after a meal? How bothersome are bright lights to you on a scale of 1 to 3? And so those scores were also higher in patients with discordant OI. We also found in this group that migraine diagnosis at age 10 or younger increased the risk of a diagnosis of discordant OI by over 8-fold. Okay, let's talk about treatment. So there's 3 pillars of good migraine treatment. There's lifestyle, or like the non-pharmacological interventions. Then we have acute abortive treatments, and these are treatments you take when you have a migraine, right? So I'm starting to feel my aura, I'm gonna take my triptan. And then there's prevention, which are medications you take every day or every month to prevent migraines. So depending on your frequency, you will be offered several of these options. And the critical question to ask is, how many zero pain days do you have every month? Very often, the first answer I will get to the headache frequency monthly, my fellows will come to me and say, oh, this patient has 6 migraine days a month. Well, did you ask them how many other days of headache they have? Because they probably have more than that, right? And they might be telling you how many they're treating, but we really want to get at the core issue, which is pain freedom. And is this an episodic disorder, Or has this patient chronified? Everyone gets lifestyle, right? And we call this at our center living the GABA life, right? Which is going to back to the idea that migraine is for a lot of patients a disorder of an imbalance in excitatory and inhibitory neurotransmitters. And so we want to think about ways to live that increase our inhibitory activity or tone in the brain. This involves getting good sleep, less caffeine, right? Caffeine's an adenosine blocker, which we know is important in pain sensitization. Stress management, right? And I don't talk about therapy or stress management until the end of the visit, until I've gone through physiology and talked about why a patient might have migraine, because patients are almost always receptive to the idea of therapy if there's a reason, right? And if they feel like this is part of a mechanism that's leading to their pain, and you're not sort of just saying, oh, I'm not sure I believe you, you should go get therapy. But there's really good evidence in chronic migraine, as in other nociplastic disorders, that CBT is really effective. Hydration is really important. Magnesium is also really important. So if your patient does have maybe 2 to 4 days of migraines, then these acute treatments are very effective and appropriate, right? You take them at the onset of your migraine. The timing is really important. You want to sort of try to time when a patient takes their medicine to the very beginning of their migraine. If you take it too late or too early, it's not effective. So prevention migraine treatments. About 5 years ago, a new class of medications came out on the market that block calcitonin gene-related peptide, or CGRP. It's an inflammatory molecule that's released by the trigeminal vascular system, that ganglia I mentioned early in the talk. That's really the sort of the migraine hub, right? And that's the part of the brain that's active when it's an episodic disorder, right? When it's local, right? We have to think differently if a patient comes in with chronic migraine. And so when a patient comes in, we have like 20 or 25 different medications that we could try. And this article came out a couple of years ago in The Atlantic, and I think it's still very relevant, which is that we have all these medicines, but experts are still trying to figure out why the same treatment might work wonderfully for one person and not at all for another. And this is one very important research gap in migraine. We do have this table, which I hate. It is evidence-based, and I put that in quotes, prevention treatments, and insurance companies love to use this as a way to make physicians try medications that are older and cheaper for their patients before they try some of the newer monoclonal. And I hate this table because the clinical trials that led to these level A or level B evidence exclude people like Paula, right? If you have a chronic overlapping pain condition, you are excluded from every migraine trial. So how do I know what drug to give Paula, right? And as Dan mentioned, a lot of these peripherally acting medications that are, become very popular and are on television a lot are peripherally acting medications, right? And it's a 3 to 6 month trial for a lot of these medications. Whereas a lot of the older medications, like gabapentin, I have found work a lot better in patients who have chronic overlapping pain conditions. And this is work from our K-12 showing that, using our research registry, we found patients who have nociplastic pain, and we just kind of define this as an arbitrary FM score of 16 or more, had a 12.5 times greater likelihood of responding to gabapentin, which is level U evidence, right? You try to find a migraine specialist who's excited about gabapentin, and you will be trying for a long time. But I love gabapentin for patients who have chronic migraine. And so the really critical question when I'm talking to a patient about treatment is we need to figure out why you have migraine, and then we pick a treatment based on why you have migraine, right? It's simple. Yes, neuronal excitability, neural network, right? This is as my grandmother used to say, your lot in life, right? The brain you were born with. And I thought this is one of my first patients with chronic migraine that I saw when I was an attending at Sinai. And I remember writing this in the chart because I found it so compelling, right? James, who was 21, who had to take a break from college because his chronic migraine was so debilitating, and his mom came in after waiting, several months to potentially a year at our center. And she said something that I will never forget, which is James had a twin brother, and she said, I learned really quickly, and it's a fraternal twin, that James I couldn't ever put him on the infant car seat that was near the sunny side, right? Or he would scream the entire drive. So instinctively, she would always put James on the shady side of the car. He got migraine at a very young age, and so clearly there's something intrinsic for a lot of people that sets them up for a life with migraine. And then there's also the environmental, right? Our life experiences that can certainly influence if we get migraine, sensory activation, right? Some people report bright lights, stress, pain. And then there's the important bottom up, which I think is very important for patients who have neck issues, right? So we have the cervical neck anatomy can also trigger migraines. Okay, so in summary, migraine is a whole nervous system disorder. It involves alterations of the gain of multiple sensory systems. If there's one thing I want you to take away from today, that's it. There's heightened exteroception and interoception that might explain some of the whole body symptoms that we have with patients with migraine report. And that successful treatment is going to require a multimodal approach, and it's going to take time, right? Because we are trying to rewire the brain. So I have lots of people to thank. At our headache center, we have a terrific team. I mentioned Maya as our project coordinator. I have a fantastic research mentor, Jessica Robinson-Papp, who saw a kernel of potential in me when I joined Mount Sinai and mentored me through the challenging transition of becoming a clinician researcher. Having bench science experience does not help. If anything, you're starting below zero. And then my whole K-12 mentoring committee, who has been truly stupendous and supportive and helped me in every way possible, from study design to public speaking. I also want to thank the K-12 committee and Laura Wagner for creating this funding mechanism, because it's allowed me to do work that I love. My daughter is a huge Taylor Swift fan, and so I promised her that I would put something from Taylor Swift in my talk. And Taylor Swift said at one of the Grammy Awards that she won is that the award is the work, and that's really how I feel. I love my job, and I'm so grateful to be able to do it. So thank you all.
We have time for one question. Go ahead, Andrew.
Okay, awesome. I'll try to make it a good one. So Bridget, something I think is really fascinating about the discordant thing is, have you been able to watch them over multiple visits and see if they're always discordant?
No, you've not done that. No, but that would be a great thing to do.
So something that I think is interesting is if somebody had this experience even 20% of the time, they could be having a classically conditioned response every time they get on the tilt table, whether or not they're actually showing all of the same physiological effects. So it might be really interesting to see whether or not consistently see discordant and not discordant.
Yeah, one of the things we are planning on doing is measuring cortisol responses during the tilt table, so to see what happens to the HPA axis, because I think that actually it's less likely that someone's going to become discordant on the second time, right? It's a little bit anxiety provoking for I think a lot of patients, and so that stress response might be what's fueling some of the discomfort.
Great, thanks so much. We'll have about a 15-minute break and then reconvene.